now. And I'm going to start letting everyone in. What is happening here? Sorry about this. All right, everybody, welcome. I'm going to give you all just a couple seconds to get settled and join. We have everyone's microphone and camera turned off for security reasons. We are asking you to please post your questions. You can post them anytime during the talk. Just post them in the chat feature to the bottom right hand of your screen. And this webinar is being recorded. It will be on our social media channels, and it will also be on our website, the lsuhealthfoundation.org website, starting tomorrow. But it will be live on Facebook. And let's see, please message me if you have any questions. You can message me in the bottom right chat corner. You can send me an email at scusimano@lsuhealthfoundation.org. And now I'd like to introduce the Chief Development Officer for the LSU Health Foundation, Crystal Oliveira, to kick us off. Thank you.
Good morning, everybody. It's so great to see all of you. We are kicking off our webinar expert series, and we are on neuroendocrine, as it is Pancreatic Cancer Awareness Month, I believe. And I have the great privilege of introducing Dr. J. Philip Boudreaux. He is our professor of surgery at LSU Health Sciences Center with over 35 years as an experienced surgeon, transplant surgeon, critical care physician. He is a founding member of the internationally recognized NOLA-NETS, which is New Orleans, Louisiana Neuroendocrine Tumor Specialist, part of a multidisciplinary team and clinic, and a partnership with LSU Health Sciences Center and the Ochsner-Kenner Clinic out in Ochsner-Kenner. Dr. Boudreaux, it's really great to see you. I have been a big fan of you and the team out there since I started here 5 years ago, so it's really an honor and privilege to have you as our expert this month, and welcome.
Thank you. Pleasure to be here.
Now I'll let you take it away.
Okie doke. Well, so a few things people may or may not be aware of is that, well, this clinic is established for the care of patients with neuroendocrine tumors, which are typically slow-growing types of cancers that can start in the pancreas. They can also start in the lung or the intestinal tract, anywhere from the mouth to the other end. And those are probably the three most common places these things start, but they can start in almost any organ in the body. A few famous people who have had neuroendocrine tumors of the pancreas include Steve Jobs and Aretha Franklin. Another famous person that some people may or may not remember was Dave Thomas, the founder of Wendy's, had a carcinoid cancer, which was an intestinal neuroendocrine tumor. And they call these things neuroendocrine tumors because under the microscope, they look kind of funny. They have some developmentally some neural elements, but they also have some endocrine elements, which means an endocrine organ
Oh, Dr. Boudreaux, I think you're muted.
Am I back on now?
You're back on.
Did you get any of that?
We missed like 30 seconds.
Oh, sorry. Well, so these neuroendocrine tumors can start anywhere from the pancreas to the intestinal tract to the lung. They have a predisposition. They all have one commonality, and they like to go to the liver. So some of these patients show up with liver problems related to their tumor. These tumors are called neuroendocrine tumors because they grow slow like nerves. They have some neural development elements under the microscope. And they're called endocrine because endocrine means you make a compound that goes into the bloodstream, circulates around, goes somewhere else, and causes an effect somewhere else. So that would be the endocrine piece or hormone piece of the tumor. And these can make these compounds that go all over the place and cause weird effects, not so much necessarily from the tumor, but maybe the chemical it produces can cause weird symptoms. A couple of famous people that have had neuroendocrine tumors, Aretha Franklin and Steve Jobs both had pancreatic neuroendocrine tumors. which are slow-growing forms of pancreatic cancer. Dave Thomas, the founder of Wendy's hamburger chain, had a carcinoid cancer, which is a neuroendocrine tumor of the intestinal tract. These things are more common than we thought, and the incidence seems to be on the rise. The incidence of new cases per year is around 7 per 100,000, but there's an estimate of about 100,000 people in this country have a neuroendocrine tumor right now. About half of them know they have it. The other half don't know yet. Because they're slow and insidious and the symptoms can be vague, they're sometimes difficult to diagnose early until they produce either symptoms from the effect of the tumor pressing on something or blocking something. Remember, tumors of the GI tract are not real smart. They know only how to do one of three things. They can block, obstruct, they can bleed, or they can perforate and blow a hole. This is really rarely a complication of these types of tumors, but blockage, obstruction, and bleeding are pretty common. Sometimes these tumors produce a chemical called serotonin, which causes hot flashes, can cause diarrhea, can cause chest palpitations, can cause asthma-like symptoms in some cases, or can cause all of the above or any combination. That's called carcinoid syndrome. The most common presentation is hot flashes and flushing. It's not associated with menopause. And because diarrhea and belly pain and cramping is a common symptom, our group was speaking to a large patient support group of patients that had this problem. And, we were telling them, when we teach medical students physical diagnosis and they're trying to learn all these things about how do you figure out what's going on with a patient, you listen to their story. If you're hearing hoofbeats, think horses, not zebras. Common things happen the most often. So if you think of the common stuff, most of the time you'll be right. Well, these patients have common symptoms due to a rare disease. So we were telling them, we need to think about a zebra rather than a horse when you hear your story to make the diagnosis, because you have to make specific tests and investigations to really pick this thing up. And so that sort of caught on. The patient said, we are kind of like zebras, aren't we? Well, it sort of stuck, and eventually that became their official moniker, just like you have a pink ribbon for breast cancer and a different color ribbon for everybody. Disease has their own colored ribbon. Patients with neuroendocrine tumors have a black and white striped zebra ribbon, and so they refer to themselves oftentimes as zebras. These tumors, like I said, can be insidious in their onset and difficult to diagnose, and even more difficult to treat, because sometimes they can get quite large before they are discovered and can require sometimes some very aggressive therapy to deal with them. This clinic has had some experience with that problem. We started working with a couple of experts in this field back in the mid-90s when they joined me at LSU. They came to us, Dr. Lowell Anthony from Vanderbilt and Dr. Gene Waltering from University of Oregon. And they're pretty much experts in this disease and had invented a new treatment, the first to give it in this country, and did it right here at New Orleans and Charity Hospital, a treatment called PRRT, which stands for Peptide Receptor Radiotherapy. It means you take a molecule, which is a peptide, a protein, and you smarten it up the way it can bind to a receptor on a tumor and stick to that tumor, and then you put a radioactive molecule on the end of that molecule. You could put a light bulb on it to make a picture and see where one is, or you could put an atom bomb on the end of it and it goes in there like a guided missile and nukes off tumor. Well, they were the first to come up with that concept of nuking tumors biochemically, and did it right here at Charity Hospital. And the isotope they used was indium-111, and people came from all over the country to be candidates for this therapy because they had kind of come to the end of their rope. A lot of times they were not candidates for this therapy for one reason or another. Sometimes they just didn't have enough receptor binding, so there was not enough attraction of the molecule to the tumor. It just wasn't sticky enough in their particular case to be candidates for that treatment, so it would have been a wasted dose. But they sent them to me because they had really big tumors in their liver, and they were in trouble and had all kinds of problems. And so we tried to figure out ways to fix them and help them. And the first 100 patients we operated on or so, they were mostly sent here to us on hospice and in really bad shape. Many had lost 50 to 100 pounds. We were able to take care of their problems and operate on them. And 85 of those first 100 went back home, went off a hospice, and some of them, many of whom went back to work and got off their pain medicines and everything. So this was a very interesting thing for me, because it's not that common. You can take somebody who's in stage 4 disease and turn them into no evidence of disease and back to a useful and productive life, and added many years to their survival. We all wanted to be together in the same place at the same time. We would meet after work in the evenings on Tuesday night and have our own ad hoc tumor board, because one of us, our office was at downtown at LSU. My office was at Mercy Hospital, where we were doing our transplants. Dr. Anthony was at Baptist Hospital. And so we all wanted to be in the same place, in the same place together at the same time. Then the Hurricane Katrina hit, and we all lost all of our offices and hospitals and practices and everything. And we ended up on a hurricane in Baton Rouge, and we're able to meet together in Baton Rouge in borrowed clinic space from a surgical oncologist, LSU faculty member, friend of ours, Dr. Benton DuPont. And they would drive up from New Orleans, and I was living in Baton Rouge, and we would have clinic all together at the same time. And so we saw patients in exile, basically, as a multi-specialty. The patients stayed in the room, the doctors went in and out, a nurse specialist went in and out. We brought in our nutritionist, the nutritionist went in and out. So it was a one-stop shop for the patient, instead of having to go to 3 different doctors' offices and 3 different clinics and get lab tests done in 3 different hospitals and all that sort of stuff. And that model really worked. And we modeled it after a program in Uppsala, Sweden. And people came. And about a year later, when we could get back to New Orleans, we found some usable clinic space in a hospital that was coming back online. We wanted to be near an airport, near an interstate, and the hospital here, Kenner, fit that bill and had available space. We borrowed space in the orthopedic clinic for about a year or 2, and it said orthopedics over the door. The LSU orthopedics department loaned us some couple of exam rooms, and to see patients in, and another exam room was our office, a little 10 by 10 space, and we had 2 picnic tables, a few chairs, 2 computers, a phone, 2 phones, 3 doctors, 2 nurses, a nutritionist, and somebody helped with the phones, and that was our office, and we had some together time. We've now expanded into our own space of about 7,500 square feet. We have 18 people working in this office, and we have gastroenterology, we have pathology, we have nuclear medicine, we have interventional radiology, we have medical oncology, we have surgical oncology and transplant, we have research nurses, we have nurse navigators, and basically we are now following over 4,000 new patients since reestablishing ourselves back here in New Orleans. We see about between 50 and 100 new patients a month. We have performed over 1,500 operations for patients with this disease since coming back here to Kenner. And I'm happy to report that our outcomes are 20% better at all time points at 5, 10, and 20 years than one of the best programs in the world, which is in Uppsala, Sweden. Right now, if you look at the national average for patients with this disease, their 5-year survival, if they have what's called stage 4 disease, which means it's in the liver or some other organs after it left the pancreas, for instance, or the small intestine or the lung. The national average is around a 50% at 5 years. In our program, we're happy to report over 88% 5-year survival and 78% 10-year survival, and a 58% 20-year survival in patients with what's called stage 4 disease. Now, stage 4 disease with other types of cancer, lung cancer and colon cancer and adenocarcinoma of the pancreas, it's a 6 to 18 month proposition in many cases. The national average for this disease, the 20-year survival, is in the single digits. So less than 10% survival versus 58% 20-year survival. So we think by using this multidisciplinary approach where we address nutrition, we address their immune function, we address their other medical comorbidities, and we nurse them along with other things besides surgery, we're able to eke out pretty good long-term survival and good quality of life. So we're really happy about that. These new developments that have come along in the treatment and diagnosis of this disease, we are one of the first institutions in this region to obtain the new gallium-68 PET scan, first experimentally and now it's no longer experimental. It's an FDA-approved test. Remember I said we use that smart molecule that'll bind to a tumor, and we can put a light bulb on it. Well, there's a new molecule out now called dotatate. That's just the name of it, but it binds to these somatostatin receptors on these tumors. We put a little gallium molecule, which is like the little light bulb, and we inject it in the patient. It's a very sensitive PET CT scan, much more sensitive than the older scan we used to use called an Octria scan, which was indium-based. And it just gives us 100 times more sensitivity for picking up these tumors in places we didn't expect them to show up. And that affects treatment. It also tells us that they're candidates for some of the newer therapies that have come along if they do have a positive scan. We're currently investigating a new type of scan that's going to be a copper-based isotope, which is a much more user-friendly isotope to deal with, using a radioactive copper for the light bulb on the fancy molecule that goes to the tumor. The other thing we participated in the development of, remember I said we were the first to use this peptide receptor radiotherapy using a smart bomb to go get a tumor. We were the first in this country to do that here, right here at LSU, back in the 90s. Now we have a new molecule and a new bomb, and it's lutetium-177 is the isotope. It's put on that dotatate molecule, and it goes and it binds to tumors and it cooks them off. And that's really made a significant difference in terms of our ability to control disease if it's in places we can't get to, like in the bones, for instance, or in the brain, or other places we may not choose to go remove, but can really be a boon for patients. There's new isotopes now that we're going to be investigating. There's a form of radioactive lead, if you can believe that. We think of lead as a shield, but radioactive lead is a new designer molecule, you might say, that shoots, if you think of the particles that come off of the lutetium molecule we're using now as ping pong balls, the particles that shoot off of a lead radioactivity are more like bowling balls, and they really pack a punch and can really knock some tumors back on their heels. So we're pretty excited about that therapy as well. We have, oh gosh, I would say we now have seen patients from all 50 states and several countries. We've asked to help other institutions and other countries create this multidisciplinary program, which we think is important for the care and diagnosis and treatment for these patients. It's not one person, there's no I in team. We really have a lot of people that help us get this program to where it's currently the stature it enjoys, and the great things we've been doing for patients along the way, with marked improvements in symptoms, in longevity, and quality of life, not only quantity of life. And so several of our team members are on national organizations, we have all been invited to write national guidelines for the therapy of this disease. Our nutritionists have written nationally recognized nutritional guidelines. And so we really have enjoyed some great successes here, and pretty much due to Katrina, because before we were all practicing in separate places. But once we didn't have a place, it was easy to get together to go to one place. Nobody had to give up anything to move because nobody had anything to give up. And so when you're trying to put together a multidisciplinary, multi-specialty clinic that's disease-centered, and you're pulling together a bunch of experts in their particular branch of this disease, somebody has to move. So somebody has to get a new phone number, somebody has to pack up all their charts, although now they're kind of electronical. But in those days, we were carrying boxes and boxes of paper charts. We moved on trailers when all this was happening. You have to get new cards printed. You have to decide what staff you can keep when you consolidate. Are you going to be able to keep all your people, or are you going to have to let some people go? I mean, there are a lot of issues that go into and finding a space that can accommodate everybody, all of these things. So we were just fortunate that we were able to make some lemonade out of what was initially a big box of lemons after that storm. And so I'm really grateful for all of the people and their hard work. The institutions, both LSU and Ochsner, have been extremely helpful in helping us get this program established and firmly rooted and become a national presence and a national resource, as well as a local resource for, there are about maybe a half a dozen programs that are similar to ours. Few of them have as many moving parts as ours. They may have one or two experts in their particular region of the country, but you have to travel. If you don't live in Louisiana, you have to travel far to come to one of these kind of places. There's a place on the East Coast, there's a place in Florida, there's a place on the West Coast, a couple of places on the West Coast. There's a nice program in Iowa that's probably the closest one that mimics ours. And so, yeah, we've been quite fortunate in trying to cobble together this this group of people, and most of our faculty are LSU, but we also have Oxford faculty. We have some private practitioners as part of our cadre of experts, and so basically we'll take all the help we can get. There's one other thing I wanted to try and share with you here. There are places you can go online to learn about carcinoid cancer and neuroendocrine tumors, and can Google those things. The website we have has a big resource of information for people about the disease, its natural history, some of the new treatment options. Besides these new radioactive therapies, we can do either percutaneously or laparoscopically or robotically. We can put needles into these tumors and ablate them with microwaves and cook them. We can ablate them with a thing called a nanoknife, which is not a knife at all. It's two probes that send about 3,000 volts of direct current through the tumor between the positive and the negative of the probes for a nanosecond, hence the nanoknife. And when that microscopic lightning bolt blasts through a tumor, it busts up the cell membranes of the tumor and causes cell death, but it doesn't destroy the stroma, and it doesn't produce heat, unlike microwave energy that produces heat, just like you cook an egg in the microwave. So you can use these things, these nanoknife, we can use around blood vessels or bile ducts or pancreatic ducts, and we can use them in these organs that we would otherwise not want to have collateral damage from the heat effect of the microwave. We also now we offer the robotically and minimally invasive techniques for many of these operations. We have a thing called Neoprobe guided surgery, and we were the first to develop that for this disease in this country in our group, where that same little molecule we give to make a light bulb, to make a picture, we inject it into the patient, it binds to the tumor. We wait a certain period of time to let the background dissipate, and then we go to the operating room with a little handheld thing about the size of this pen. It's basically a little Geiger counter. And just like when you're looking for coins at the beach with a metal detector, we can scan a patient in the operative with minimal incisions and scan him and beep, 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 beep. There's one, and the lights flash and numbers go off and it makes all kind of racket. So we know we can go right down there and zero in right over a tumor that may be in a hard to get to place without having to make a really big incision and exploring on a maybe. We'll know exactly where to drill down and find these things, and we can pluck them out that way. That's using the indium-based isotope. We will soon be using the copper-based isotope with that technology, which again will add much more sensitivity and specificity to our armament of weapons. We use a thing called lymphatic mapping, where we inject a blue dye into these tumors and we see where the lymphatic channels drain. So we know how much intestine we need to resect without taking too much, but we're not leaving tumor behind. And this often, many times, will allow us to spare the little valve between the small intestine and the large intestine, where traditional teaching would say you have to remove the valve and remove that part of the colon with it when the tumor is really close to the valve. About 60% of the time, we can save that valve. And you say, well, why should you care? Well, people that don't have that little valve can have challenges with diarrhea, because the purpose of the large intestine is to take everything that enters it, which is liquid, at that valve site. And by the time it gets to the other end, 8 to 10 feet later, it's transformed to a solid. So it's a big water absorber. Without the valve, you can't control the rate of liquid influx. And so people have challenges with diarrhea. Remember, I said this disease, these hormone producing tumors can cause diarrhea. So they get a double whammy if they lose that valve. So it's really important when we try and save that valve. So those are just some of the things we are able to do, and some new innovations that our team has been working on over the years. Excuse me. My phone keeps trying to blow up here. Sorry for the interruption. So anyway, how are we doing?
Good.
On our time?
We're doing great on time. We do have some questions if we're ready to start taking some of those.
Sure.
One viewer asked, is long-time use of PPIs associated with NETs?
Oh, there's a good question. So we actually did a study. A PPI are for those proton pump inhibitors. It's a class of drugs for treating people with heartburn, dyspepsia, gastroesophageal reflux, or GERD as they call it, heartburn, peptic ulcers in the stomach. So it's an acid reducer. The bunches of, they go Pepcid, Protonix, Acifex, the purple pill, Nexium, all those are kind of in that group. And it turns out that they're a really good drug to shut off acid production. So good, in fact, that sometimes the stomach senses, man, I don't have enough acid. As a result of that, the stomach then kicks out another hormone called gastrin. Because the gastrin is made in one part of the stomach, it goes into the bloodstream, hits the other part of the stomach by way of the bloodstream, and tells the acid-making part of the stomach, make me some more acid, I don't have enough. Well, sometimes people that are on this drug have elevated gastrin levels. Gastrin is a known growth factor for carcinoid tumors of the stomach. People that have a disease called autoimmune gastritis, used to be called achlorhydria, it used to be also called pernicious anemia, it's part of the same problem. These people have antibodies against their acid-producing cells of their stomach, they destroyed them. The normal reflex of the stomach is we'll make more acid, Scotty. And so gastrin comes in response to no acid, and these people have sky-high gastrin levels, and they grow these little carcinoid tumors all over their stomach, bunches of them sometimes. And sometimes they get really big, sometimes they bleed, sometimes they actually can become cancerous. If you give enough proton pump inhibitors to rats, like massive doses, you can actually produce carcinoid tumors in rats. We have seen people who have been on proton pump inhibitors. Those drugs were designed to use for 6 weeks to heal up your ulcer and quit. But because people feel good with them, it makes their stomach feel better, they take them for years. And sometimes these people have elevated blood markers that we consider to be tumor markers, the most common one being a compound in the blood called chromogranin A or CGA. And it's a very common marker we used to use, the most common one we use to follow tumor activity and tumor growth. People have a tumor of a neuroendocrine type, they had elevated chromogranin levels, you do an intervention, the levels drop down to a good level, and as long as they stay low, everybody's happy. Well, unfortunately, lots of things can affect chromogranin levels. Other diseases of the kidneys, of the livers, people that are on proton pump inhibitors oftentimes have benign elevations of their chromogranin levels. We don't have any documented cases of PPIs causing neuroendocrine tumors in humans. We have seen in our own studies elevated markers, the chromogranin levels being elevated, and when we stop the PPI, usually within 3 months or so, those levels come back down to normal. Everybody's happy, and people can stop getting all freaked out about an abnormal test. But it's just, it makes the test abnormal. It doesn't seem to make people abnormal, as far as we know. So that's a long answer to a short question.
No, that's interesting. So if y'all do have questions, please post them in the chat feature. Another question is, how has COVID changed your day-to-day life in the clinic?
Oh my, well, that's another long answer to a short question. So when COVID was at its peak back in April and May in this part of the country, we were basically, the operating rooms were shut down except for emergencies, and sometimes these people did require emergency operations. It was very tough on the patients because they were not allowed to have visitors, not allowed to have family members, nobody could be with them. So they were cooped up in their room by themselves except when the nurse came in and out. or the virtual nurse visit them on the screen. We have these virtual monitors and cameras in all the rooms where the nurse can sort of have a virtual visit. And all of our clinics were basically virtual visits for the most part. And so we had to gear up real quick and figure out how to do that. And if you're as internet savvy as I am, you can imagine what a challenge that was. So, but anyhow, we got through that and it actually worked out quite well. And now it's become a part of our main method of standard operating procedure to do. Many times we'll do virtual visits, especially for new patients that come from far away. They get a consultation and we decide, is it worth them coming here to have further treatment or additional evaluation, additional testing, or just whatever. And we can get a lot of preliminary things out of the way. So when they come here, it's a much more efficient, compressed time they need to spend here to get everything done they need to get done. So that's worked out very well for us, actually. So we're definitely using telemedicine now more than we ever have, and I think that methodology is here to stay, and it's a good thing.
Mm-hmm.
Now, fortunately, the rules of governing, and this was a statewide rule, it wasn't our rule, about limits on surgery. Elective surgery is now allowed again, so you can do planned procedures that are not emergencies. One family member can stay with the patient now, and that's a relaxation in terms of the in-hospital side. One person can come with the patient to clinic. Before, they couldn't even come in the clinic building. They were kind of one person and one at a time only kind of thing. One person at a time in the waiting room. All that sort of stuff is now relaxed. Everybody still gets their temperature taken to enter the building and get screened with a questionnaire to make sure they don't have symptoms, et cetera, et cetera. So we're doing kind of the standard CDC guidelines. But that was a challenge for a while, and it was a challenge for patients. Patients also were afraid to travel, and you can't blame them. So all of those things kind of factored in, but we seem to have at least gotten the worst of that. Right now, knock on wood, we have no COVID patients in our hospital, inpatient, as of 10:30 on the 17th. But that can change in a heartbeat.
Right. But that's nice to hear.
Yes,
that's
ma'am.
A hopeful note. We can take just a couple more questions. You did say that you were seeing more of these types of tumors. Did you, maybe I missed that, but did you explain why, or what is your theory for why you're seeing more?
Well, there's a lot of theory. The incidence of these tumors is on the rise. It used to be about 3 or 4 per 100,000. Now the latest estimates around 7 per 100,000 of new cases per year in this country. We used to think it was because of better detection, and we definitely have better detection. We have endoscopic ultrasound where we can put a scope down a person's mouth and get a really good look at the pancreas for finding all kinds of things in the pancreas where you couldn't see well before with regular CAT scans and MRI scans were the two most conventional imaging studies. MRI is magnetic resonance imaging. It uses magnets to make a picture as opposed to CAT scan, which uses x-rays. So there are different modalities, but it gives us the idea as a way of looking inside of people. Intraoperative ultrasound through the scope, through the endoscope, it's called EUS or endoscopic ultrasound. You can look inside lungs, you can look at the pancreas, and you can sometimes get a pretty good look at bile ducts and liver as well. And other places you can look with this modality. So there is better detection for sure for pancreatic cancer, both adenocarcinoma, standard pancreatic cancer, and earlier detection, as well as neuroendocrine cancer of the pancreas. The neuroendocrine cancer of the pancreas start in the islet cells. Those are the little globules of cells, the hormonal part of the pancreas that makes insulin, makes glucagon, but it can make any other hormone it wants to, depending on its mood and what the tumor decides to do. The problem with the ones that when it makes too much insulin, people fall down with low blood sugars for no reason, with no warning, and boom, they're out cold. And that's not what you want to happen if you're a cross-country truck driver, for instance,
Right.
or a pilot an airplane, or whatever your occupation is. It's not conducive to good outcomes. So those people are profoundly symptomatic. But when you look at the incidence of all other cancers, if you say, well, this is all due to better detection because we got better imaging, we got better diagnostic tools, we have better blood markers, we have all kinds of stuff, then the incidence of all other cancers should also be on the rise in parallel at about the same. But the incidence of other cancers is pretty flat. But the incidence of neuroendocrine cancer is rising at a rate higher than the others. And at this moment in time, we have no idea why. It's one of those things that makes you go, just can't explain right now.
But you're working.
There's lots of things about this disease that are puzzling. Why is it that the tumor that starts in a person's small intestine is about the size of a garden pea? About like that. And when you open them up, you see it's spread to the lymph nodes, and the lymph nodes, the tumors are about the size of walnuts. And then you look at the liver, and there's a tumor in the liver the size of a cantaloupe. Now, the one that got to the liver got there last. The one that's been in the gut may have been there for several years, but never got any bigger than a garden pea. But the one in the liver just going to town and having a good old time. So why is that? We think in this particular case, it's more about environment than heredity, because all of these should be progenitors from the same origin. They all came from the same place. So why isn't the daughter like the mother and the granddaughter? Because they're all clones of the original thing that started in the gut, but they don't act the same. They act totally differently. They have different growth rates. They have different biological behaviors. They're sensitive to different types of drugs and therapies. And so we think it's because of where they are. There's other growth factors, perhaps in the liver, that seems to nourish these things and allow them to really go to town. That's the current theory. Difficult to prove. But anyhow, so there's lots of stuff that's very puzzling about this disease. The good news is it's slow growing. So we have the luxury of you can fix one side of the liver and let it recover, and then come back 6 months later and fix the other side. You don't have to fix the whole thing all at once if the liver is really burdened with a lot of tumor that where it would be too much, quote, too much. There's hard to believe a surgeon would say this, but there's such a thing as too much surgery. And so you have to know kind of when to hold them and when to fold them. And so sometimes better is the worst enemy of good. So you make one side good, let it recover, and you go back and do the other side. With other types of cancers that have spread to the liver, unfortunately, you don't have the luxury of time on your side. You pretty much have to get it all got at the get-go when you're there at that time, because you may not get a second chance later. That's the thing.
Okay.
If that clears it up a little for you. Clear as mud.
If you all have any more questions, please post them now. You can, to support this kind of research and the work that the NOLA NETS Clinic and Dr. Boudreaux and his colleagues are doing, we posted the link in the chat. You can go there to support their work. And to see a recording of this webinar, you can visit lsuhealthfoundation.org starting tomorrow to see the recording. And then you can also check our Facebook Facebook channel for that recording too.
I'd like to speak a little bit about the research piece, if you don't mind.
Sure, please.
So we probably have about 10 different types of clinical trial and research projects going on, as well as some bench research and laboratory research. Our laboratory, pioneered by Dr. Woltering, is one of, if not the only probably laboratory, last time I checked, in the country that could actually grow these neuroendocrine tumors, because they're really hard to grow. And so when we're in the operating room, we make it our business to take out some of this tumor in the living state, cryopreserve it, we freeze it in such a way in liquid nitrogen that we can then thaw it out later. And when we do a batch run, we'll pull out a bunch of samples and run them and revive them and grow them in the laboratory. Then when we get them to grow, we can test them with different things to see what basically gets them to die. Traditional chemotherapy doesn't work for this disease. And for the longest time, the traditional teaching was nothing really worked, except this synthetic hormone preparation we give called octreotide and a new one called lanreotide. Those are the two compounds that are now available. They're given by a once-a-month depot injection, lasts a month, and you get another shot. It binds to those same receptors on the tumor, and when it binds to those tumors, it shuts off their hormone production, and it slows down their growth. So we use it like chemotherapy, even though it's not chemotherapy. And then there are other agents that were not traditionally thought of as chemotherapy that do work quite nicely for controlling some of these tumors. So that's kind of an important thing. We're also looking at we're establishing a big biobank. We have about 1,000 specimens in the biobank, so that when other researchers call and said, hey, we just invented the best test since sliced bread. Can you send us some specimens so we can test your tumor, and we'll tell you everything you want to know about that cancer? Well, that's a spectacular opportunity, but costs money to keep these specimens preserved in liquid nitrogen and taken care of and monitored and so on and so forth. Continuous monitoring, 24 hours a day, 7 days a week. We also are looking at certain blood markers. And what we're trying to do, because doing this tissue culture stuff and all these things and taking these apart at a molecular level, which is some other things we're doing, working with the cancer center and the genetics labs and some of those gene jockey types, I call them. They're some super smart people that know all about how to take genes apart and analyze them and figure out things to try and figure out why do these tumors cause so much intensive scarring and choking and stricturing. It's just one of the problems with these tumors. They call it this thing called desmoplastic reaction. It causes a lot of way more buildup of scar and inflammatory tissue around the tumor than the tumor itself. And they can block off the intestine or block off important structures in the liver or in the pancreas or sometimes the ureters to the kidneys or other things. And that's a really vexing problem. Once that starts, it's hard to turn it off. Well, we don't know why exactly that is, but we're finding the genes that seem to be the on-off switch for that, and are making some progress in that arena. But we're also looking for some blood markers that when we can draw a blood sample and analyze the blood, we can say, does this person does or does not have a neuroendocrine tumor, and answer that question. That'd be worth knowing, and not have to do a $3,000 scan to find out. We can also maybe have some predictive information about the biology of this tumor and how it's going to behave and what it might respond to and what sort of therapy we should pursue, at least as the initial outset, to see kind of what's the best bullet to be putting in our gun to go after these things with. So those things are super important in research. And guess what? That kind of stuff's not cheap, unfortunately.
Right.
It's the nature of the beast. So this is a plea for help in that arena.
Well, to that point, we did post the link where you can find out more information about what they're doing and also support them. And I also posted their Facebook, the Facebook channel for NOLA Nets, which gives you lots of information and gives you patient profiles, tells you more about everything they're doing there.
And the good news is if you call on the phone, you'll still get a human.
Yeah. And everybody in that office is so nice, like a really great group of people there.
Well, they all get it. They all understand and they see, because they see the results. They see people come in wheelchairs, and the next time they see them, they're walking in looking great. So it's been a really rewarding thing to see people that go from really being super sick to super well. It doesn't always go that way, but when it does, it really gets you, and that gives us courage and encouragement to go again and try it again and keep going and forge ahead. So everybody here really is pulling on the same rope and really wants the best for our patients and try to gain some more understanding into the best ways to manage this disease. We have a tumor board that meets every week where we talk about the patients and discuss, okay, what arm of the 10 different things we could do as treatment options, which one are we going to do and which one are we going to do first? Sequencing is very important. How you sequence these different therapies, operations, and other treatments is really important in terms of your success, your outcomes, and your ability to do the next treatment. We don't want to close the door on one treatment by picking the wrong one first, and that knocks them out the box for the other, because now the risk and the complication risk may be too high because they had this other thing first. So we want to make sure we do the proper sequencing, and everybody's different depending on their biology of their tumor, its growth rate, its location. It's like real estate, location, location, location. Where it is dictates a lot about what you can do for it. And that's true with just about any cancer, not just neuroendocrine cancer. So those things are all kind of factored in when we have our tumor boards to try and figure out, okay, this is really custom care based on what's going with that patient at that particular moment in time. And at another point in time, the answer may be different. So reevaluation is important. So patients are constantly being reevaluated, reassessed, because they have it a long time. Remember, they can live for years with this disease. And so the answer that was true now may not be true 3, 4, 5 years from now, or even 6 months from now. Now it's a different answer because something's changed. So you have to monitor, you have to keep track of things. So these patients are lifelong monitoring with all these new modalities and new scans and all this stuff. Hopefully we'll be able to just do a blood test at some point in the future, not have to go get a big scan. So those kind of things I think are really important. And I think that's what's in the future.
Well, that's great. That's very inspiring to hear about. Thank you for sharing all of that. And I did want to point out that you had a patient on here who said, Nola, that NETS is very helpful, great to work with. I'm a patient, life-saving experience. Dr. B is the best.
Oh, great. Thank you. Appreciate that.
All right. I think that that's all of our questions, and we're going to go ahead and wrap up. Oh yeah, somebody's asking if we can view this webinar after it's finished. Yes, it will be on lsuhealthfoundation.org/news. So go to the news section. It'll be there, and it will also be on our Facebook page. And you can also email me or message me directly, and I'll send it to everyone. It'll be available in just a couple hours.
Great. Excellent.
Right.
Thank you.
Dr. Boudreaux. Thank you so much. And
the miracles of the internet.
Yeah. And everybody take care, and we'll see you soon. Thank you.
Okie doke. Thank you. Thanks for coming, everybody.
Bye.